ನಿನಗೆ ಲಿಂಕ್ ಕಳಿಸಿದ್ದೀನಿ ನೋಡು, ನಿನಗೆ ಲಿಂಕ್ ಕಳಿಸಿದ್ದೀನಿ. ಲೈವ್ ಬರ್ತೈತೆ ನೋಡಿ.
Good morning to one and all present here. On behalf of the Maharaja Institute of Technology, myself, I am Saitra KG, Assistant Professor, Department of Information Science and Engineering. I would like to extend a warm welcome to all the dignitaries on the dais, off the dais, and faculty members to a faculty development program on convergence and AI and IoT for smart health. Welcome you all. We are privileged to have our today's session speaker, Dr. Namrata NR, Associate Professor of Pathology, Kidwai Memorial Institute of Oncology, Bangalore. Welcome, you, ma'am. Now, I request Dr. D.S. Gurusil to welcome our speaker. I would like to welcome Dr. D.S. Gurusil, Professor, Department of Studies in Computer Science, University of Mysore. Welcome. And I would like to welcome Dr. Shivashankar, Pathologist, Medical Officer, K.R. Nagara Government Hospital. I welcome you, sir. And I also welcome Dr. Raghavendra, HOD, Department of Pathology, Kidwai Institute of Oncology. Welcome, you, sir. And I also welcome Dr. Amar Kumar. Welcome, you, sir. Preceding, I am pleased to present a brief biodata of today's eminent speaker, Dr. Namrata NR. MD Pathology from KIMS Bangalore, Rajiv Gandhi Medical University of Health Science, Karnataka, and Diploma in Clinical Pathology from Bangalore Medical College, Rajiv Gandhi Medical University of Health Science, Bangalore, and Bachelor's in Medicine and Bachelor in Surgery in 1996 from JJM Medical College, Davangere, Kuvempu University, and she is working in Department of Pathology, Kidwai Institute of Oncology, Bangalore from 2002. Undergone nephropathology training at TGI, Chandigarh, India, and undergone training in liquid-based cytology at TGI, Chandigarh, India. And she has obtained various activities and achievements. She has published 15 papers in oncopathology field in national and international medical journals, and she has played active role in interlaboratory quality control, and she has taught medical students DM, MD, Diploma in National Code, MD pathology students throughout the entire state. She has also taught BSc, MND students and nursing students. Dr. Namrata NR has served with various academic and administrative activities of professional organizations such as Life Member of Indian Academy of Pathologists and Microbiologists, Memorial Institute of Oncology, member of Indian Society of Medical Statistics, member Governing Council Kala Khatun Vidya Sansthe Tiptur, and faculty of Medicine Rajiv Gandhi University of Health Science Bangalore, registered member Karnataka Medical Council. Now I kindly request Dr. Namrata and Anand to take over today's session.
Can you hear me? Yes, Pranava. Good morning today. Everyone, actually, most of you are from the technological field, so can I ask you one question? Why all of you are here today? You want to learn AI or do you want to learn medicine, a bit of it? What is your intention? Because yesterday all of you must have heard a lot about AI and you will learn AI also in future. So most of you, okay, let me start with it. Today, my aim is to just brief you around the Department of Pathology because as you all know, I am a pathologist and I'm working from Kidwai from past 22 years. So oncology, so Kidwai, if people are, most of you, if you are not aware, Kidwai is a state cancer institute. It's the only state cancer institute in Canada. So any poor patients or even the corporate hospitals for anything, even for the second opinions, they do come for us. So it's one of the reputed institutes in Canada. So probably I'll go nearby again. I can't read. Yeah. So for you all to introduce to the medical departments, what we go through. So most of you are yeah. So these are the clinical, few of the clinical departments what we have. And most of you are aware only about this clinical departments actually. So these are the few departments which you are aware of, like anesthesia, cardiothoracic surgery, dermatology, emergency medicine, and the pathology is studied here. So any idea, anyone of you, any idea what a pathologist do? So all of you know about emergency medicine, anesthesia, both in India, OT. Most of you understand Kannada, right? Yeah. Okay. So you know Anybody Kannada play ಮಾಡ್ತಾರೆ OT-ನಲ್ಲಿ before your any operation they give you anesthesia. So that is the kind of work they do. Those specialists what all with the pathology. And what is your connection with your AI with pathology? So okay. So let me introduce. That's exactly the reason why I'm come here to say what a pathologist does. So these are few basic sciences department. This is not a complete list of all your medical departments, but basic sciences play a huge role in the research field, including your A. So pathology department is the bridge between your medicine and research, and all departments, entire departments, you name any department in the medical field, if they have to send any investigations, whether it's a blood test or whether it's a specimen or any kind of fluid, they have to come to the department of pathology. So the moment any patient or even a health checkup, you people, the moment you enter the hospitals, you undergo any of your blood tests, any of your master health checkup, whether you go or any of your diseases if you go, the moment you enter the hospital, first ಹೇಳೋದು ಹೋಗಿ test ಮಾಡಿಸ್ಕೊಂತಾರೆ. First we have to get the reports. So that is where does the specimen or your blood samples go? That is the department of pathology. So we are like a movie director, the back playing a role, not coming in the front. That's exactly a pathologist is. So the pathologists basically interact with all the departments, and the conformity, the role and the responsibility of a pathologist is they are the ones who actually give the confirmative diagnosis, especially in the case of cancers. The screening, fine, orthopedics, radiology plays a role, but when it comes to neoplasia or when it comes to your cancer, the major specimens what we receive in pathology is with the apprehension with the patient, even with the clinician saying that, madam, cancer is there, first hit. Now, how fast you can say, please tell us. So pathologists examine the pathology slides under the microscope. They diagnose with the help of glass slides. That is the traditional technology. And with the new technology, with the AI and all, we might change. So that's exactly here. So with the traditional glass slides, we stain this biopsy slides with staining. The regular one is HLE, which we call hematoxylin and eosin. Obviously, an unstained tissue we cannot see. Our eyes are not used to seeing anything without color. So we stain it. And even after staining, even with the experienced pathologists, we have intra and inter-observer variability. That's exactly one more role where AI can play a role. And there is limited agreement even with the experienced pathologists. So automated approaches are nowadays the rule. So digital imaging is the first step. So this you must have heard about the history of how your AI is coming into the practice. So I'm going to concentrate more about the pathology and AI. So if you say pathology is a huge department, one of the huge departments in the medical field, so you have a lot of subspecialties. So like the regular your screening tests or your master health checkups, everything like your blood sugar, urine, your hormonal levels like thyroid, anything comes to the department of clinical pathology. So most of the non-cancerous samples. The second one is the hematology or your hemato-oncology. Why I have written two divisions is hematology itself is a huge subject. It considers both, it has both oncology and oncology and the cancer exam. Okay. So hemato-oncology basically deals with blood cancers and it's one of the emergency units of pathology. So we have your non-emergency departments in medicine. So the pathology and only we are 9 to 4 job or one of the best jobs what we choose, but that's not true actually. When it comes to hematology, we are always on toes. Blood cancer comes. Why is it so? Because the blood cancers, most of them are acute. You mean to say acute means today I see a patient, today I walks into the patient, If he walks into the hospital, within 1 2 hours he collapses if we don't attend him. They're very acute. So that's exactly where AI can play a major role. So the other unit is histopathology. It takes many weeks for reporting. You might have heard in the hospitals when the operation like the report that's not the delay of the pathology. It's because I will go through the procedures later in my second half of my talk. Histopathology itself will take time, the procedure, because we cannot just cut the tissue in the air. So we need a huge process goes in between before you get the tissue on the slide. So that takes a lot of time. So histopathology is one actually it takes many weeks for reporting as such. And it definitely makes your ancillary test it's huge, pathology is huge. So just seeing one class slide, we will not be able to say most of the time saying that yes, this is cancer, this is not cancer. And in cancers, what are the kinds of cancer? Because cancer treatment doesn't depend upon one saying that yes, it's positive or negative. It's not that. It is like what other different kinds of cancers you have apart from your system wise. So if I have any disease in the uterine, it is like endometrial carcinoma, ovarian carcinoma. Depending on the organ system, what are the solid we call it as solid tumors. ಅಂದರೆ ಯಾವ organ ಅಲ್ಲಿ ಏನು ಕ್ಯಾನ್ಸರ್ ಇದೆ ಅದಕ್ಕೆ ನಾವು ಹೇಳುದು. Cervical cancers you must have heard, breast carcinomas, everything. Any organs which we possess human can have cancers. So that is one of the solid tumors. Okay, that is major histopathology. So that diagnosis of saying cancer or not cancerous, it doesn't depend upon one hematoxylin or eosin stain, which is the basic stains which we use in histopathology. So you must have heard special test ಆಗಬೇಕು ನಾವು ಹೇಳಕ್ಕೆ ಆಗಲ್ಲ ಈಗ ಆಗಲೇ ಒಂದು ವಾರ ಕಾಯ್ದಿದ್ದಾರೆ ನಮ್ಮ ಹಾಸ್ಪಿಟಲಲ್ಲಿ. Again, this doctor is asking 1 more 10 days for asking for immunohistochemistry. Is this the fault of the doctor or is it the fault of the hospital? Or is it the procedure itself is taking such a long time? And you, as educated people, should understand. At least this we cannot say for rural people saying that as such a procedure is taking time. The patient is dying and we say, yeah, then you had it. So where do we fall? So where in my talk I'm going to introduce the Department of Pathology. And all of you are youngsters, all of you are keen to know about AI, artificial intelligence, and how intelligence versus artificial intelligence are right now existing. Maybe in future, artificial intelligence will take over all the fields, but before taking over, what precautions do we have to implement? Especially in the field of medicines right now. That's exactly why I'm introducing you all to Department of Pathology. So where are the false reports or where all AI can make a difference and where all AI cannot make a difference at least for right now. That is my talk. So histopathology definitely takes time. So there is a unit of cytology. This cytology is like hematology. It gives you the report. Hematology and cytology departments, they try to give the reports on the same day. Sometimes we have issued a report within 3 to 4, that to a definitive diagnosis. Not just saying blood cancer, even the typing of the blood cancers. So, in histopathology, we have immunohistochemistry, that again takes a week. Then there is FISH. This is fluorescent in situ hybridization. So this fluorescent, I actually have photographs. I just want you to be aware of the terminologies from the initial of my talk. Later I'll show you the images. So you people have now 5 images, I shall show you the images. But before that, you should know what image it is. So this is fluorescent in situ hybridization. Then the cytology department, as I said, cytology generally is used as screening, and most of you must have heard that, generally most of you see breast cancer. They are like screening. So the next ancillary unit what we have is cytogenetics. Cytogenetics is something like the chromosomal studies. So you know about the karyotyping. Karyotyping is nothing but Humans, we have how many chromosomes? We have 23 pairs of chromosomes, so 22 pairs autosomal. One is your gender chromosome, which is on sex chromosomes, one pair. So that what chromosomes, whether your cancers are genetic, inherited, hereditary, or it's congenital. So these are medical terminologies you are going to come across in case you are taking up AI in a medical field. So congenital, it can be used to be a so that's something to do with your genetic analysis saying that is it hereditary or not. It comes from your chromosomal analysis. That is your cytogenetics department. And if the cytogenetic department says, okay, fine, these are the 922 translocation. So BCR, ABL translocation is found. That is the way of report how they say. So what next you want to see? So that can be confirmed from your molecular oncology department. So that is going to study about your nucleic acids, protein, genes, etc. Further, you're going like as if like I'm just saying like how you see in a microscope, the finer and the finer adjustments. So other units of pathology is transfusion medicine. That's to say it's a blood banking. So what AI can do in a blood banking? So blood bank, most of you have heard in the newspaper saying that yeah, the raw blood transfer must be true. Patient whatever. So most of you have heard this. So why this happens? For this to know, you should know how we screen the blood and what best methodology with your AI support we can get. So that's one of the way. Transfusion medicine is also like an emergency department which you can consider. So that also needs an AI support. So coming up to your clinical and forensic pathology, yes, lot of crimes are happening with the advance of technology. So that's also one of the field where AI can play a strong role within forensic pathology. So any other samples are left out? Can you see which goes to any other departments? No. So all the samples are coming to the Department of Pathology. So what kind of samples come for Department of Pathology? So in case you're doing artificial intelligence and imaging, so you will hear the terminology saying that this is a small specimen, this is a biopsy, this is a small specimen. These are when we are giving, we will say we are talking to Guru say, no sir, this is fluid smear, this is imprint smears, these are peripheral smears. So the difference, what is the difference? So why so many different kinds of specimens are there, and why do we study the same specimen in a different way? So there are other methods like you have T filtration for phase contrast microscopy. You have squash filtrations which actually are CNS tumors. So if you heard any good demands, that's one of the center where most of the diagnosis go on as squash filtrations. So then, obviously, it's like, clinical pathology departments like urine specimens are there, stool samples are there, effusions are there, CSF are there. So it's like, you have to accept the kind of samples unbiased. Like, you cannot say that a few of the, I shouldn't be saying this, but few of the clinicians, when they say, okay, urine sample, you don't have to test for urine sample, just send it for MRI. Okay, that's exactly. So that's not right. Because even urine sample, of course, it belongs to another, right? So a calculate, urine sample study could be a major, very important stuff with the renal diseases. MRI definitely has got its own role, but every answer doesn't come from MRI. So radiology department, I appreciate the radiology advances what are happening in your artificial intelligence. Why radiology has come up in such a big way is because of huge images. They produce images. Okay, they produce images and images are very easily studied from artificial intelligence. But what happens to that? Why pathology is coming up only now? Most of you, when I asked you, you did not know what pathology is. Because pathology, it's not as simple as radiology. It's not like, you get an image, okay, fine, you give me the analysis sample, I'll process it through my AI and I'll tell you what it is. So it's not that. So what goes through the Department of Pathology? So I have introduced the different kinds of specimens and the samples. Every kind, you name a kind of sample in the Department of Pathology. It's the one which actually they receive the sample, all kind of samples. So they receive and they diagnose. So the next, as I said earlier, the major questions which most of us, even we are worried was to give it as cancer or not cancer. So this is one of the specimen. That's a bigger specimen. No? That's a carcinoma breast specimen which we had mastectomy recently. So when I say big specimen, it refers to the big specimen there. That was a fresh specimen. So this is a small biopsy specimen. So this we call in the Department of Pathology the small biopsy specimen. As you can see, this is put on a bit of paper. This is hardly around, no less than 1 centimeter, around few mm. So if this specimen is really small, this specimen I don't think you can see at all. In the second line, yeah. So how do we process such a small sample? It's a common terminology when you look at the newspaper and say, "Ah, you doctor quoted this sample conduct." See, biopsy. Even that small sample is coming from OT for us. It's not that I plucked something so easily. No, that must have been endoscopic biopsy. So it's very small. So how will we process it? So every step in the Department of Pathology has to be done with the care. Otherwise, one patient lost definitely. We cannot be asking for rebiopsies. So that's a small biopsy. And that's sent in some fluid, if you can see. The biopsy is in some fluid there. So this is where you will have interested. So before you get this digital pathology images, so what goes through in the Department of Pathology is my talk. So just analyzing a digital microscopy, images which you get through a digital microscope is not sufficient, because if you don't know the drawbacks of how the sample is processed, you will land up somewhere else. So computational pathology is a new branch. We didn't have that. So it's a new branch, a department from the digital pathology, arising from the digital pathology. So digital pathology environment has contributed to the new branch of pathology, which is known as computational pathology. So all your AI technology will be corresponding to your computational pathology. So is this all your faculty development program saying that, okay, you just give me a good image, please don't introduce to me the Department of Pathology, just give us a good image. Is that all? So is that sufficient if I give a good image? So good image needs a good camera. So if pathology department gets a good camera, so your AI is done with it. If you have that, understanding, please, that's exactly why we have to change it. So is it? So for us, when we receive the sample, what we look at the sample is, we divide a sample like, it's pre-analytical, analytical and post-analytical. So any test we do, so any problems occurring, so we tell our PG saying that just check whether it's pre-analytical thing. Pre-analytical ಅಂದ್ರೆ ನಾವು sample ರಿಸೀವ್ ಮಾಡ್ತೀವಲ್ಲ, ಅದು ರಿಸೀವ್ ಆಗೋಕ್ಕಿಂತ ಮುಂಚೆ ಏನಾದರೂ ಪ್ರಾಬ್ಲಮ್ಸ್ ಆಗಿದೆಯಾ? The sample which is coming to the Department of Pathology, sometimes some of the hospitals, they send to the patient, ಇದನ್ನ ಹೋಗಿ ಕೊಟ್ಬಿಡಿ pathology department ಗೆ ಅಂತ. Patient ಗೆ ಏನು ಹೇಳ್ಕೊಂಡು ಬರ್ತಾನೆ ಏನಂತ ಏನು ಗೊತ್ತಿರಲ್ಲ. On the way he will be coming, he will lose the sample, or he will labeling the sample is gone, or he would have the spilled out some of the fixative, what I showed you, the bottle, half of it is spilled out, and he heads to a wrong department, he'll be running around and he comes very late. After 6-7 hours, he'll come, oh, this is the Department of Pathology. So that is your pre-analytical. Is the sample reaching the department in the right time, with the right label, with the right fixative, with the right data? That is your pre-analytical. So every sample we look at the pre-analytical part of it because that's very important. I cannot label one patient's sample into another patient. So that's a pre-analytical sample. So many times when the samples are coming from the rural areas, they wouldn't have had the fixatives, so they put normal saline. Sometimes some samples we are receiving water which we cannot process it on our own. That biopsy is a waste. So pre-analytical checkup is very important. How the sample has reached. When the sample has reached you in a good condition. So taking your pre-analytical changes are within the very good limits. So the second is your analytical. So my entire talk today in one first part and second part is my analytical part of Department of Pathology and Work. The post-analytical is what you people can do with the AI. So if the pre-analytical and analytical goes wrong, your post-analytical doesn't have any sense at all. So this is exactly where you should know pre-analytical or post. So various images, what this exactly I spoke. So depending on your images, so what you can ask me, madam, ಯಾವ images ಬರುತ್ತೆ ನೀವು Australian sample. So what are the, to know what different kinds of images you get, you should know what organs we have. Okay, different kinds of organs. And why we should know? Why we should know different kinds of organs? When you get an image, I've heard saying that madam, image analysis. Can you give me a better slide? It's all full of blood, you know. I mean, it's all full brown. You know, you make me a better slide and give me. I cannot. Because the spleen itself is very vascular. When I get a splenic biopsy or any vascular malformations, anything, the specimen is going to be like that. So I cannot clean that because that is my diagnostic feature. See, when you see any lot of blood with the specimen, definitely. I'm seeing a blood vessel, I'm seeing lot of blood as definitely is easy vascular anomaly. ಇದು ಬ್ಲಡ್ ವೆಸಲ್ ಇಂದ ಯಾರೋ ಬಂದಿದೆಯಾ ಫಸ್ಟ್ ನೋಡಿ ಏನಾದರೂ ಪೇಷಂಟ್ ಸಿಂಕೋಪಲ್ಲ ಅನ್ಯೂರಿಸಮ್ ಆಗಿದೆಯಾ ಏನಾಗಿದೆ ಫಸ್ಟ್ ನೋಡಿ otherwise sometimes we may just discard the specimen, it's very small. So we should know what organ it is. So what organ, what kind of specimens we get. So I spoke about pre-analytical, analytical, and post-analytical, and I spoke about some smears and biopsy. And then type of processing is not an easy job, so I am going to take at least, I will try to complete in within 1 hour the processing, which is actually not possible. Type of staining also matters. We have huge variety of staining here, different kinds of staining, how we do. But if the imaging, if the AI learns from all the decades of experience of the pathology department, someday we might be just talking on the way back, Dr. Agrawal saying that by the time you people age, one image might be sufficient to say this is leukemia, this is this kind of leukemia, this is anemia, this is different kinds of anemia. And I hope in future, somewhere before anemia develops, you know, in the initial stages of anemia itself, you know, some minor changes in your morphology of your RBCs, you would say, yes, you know, within a span of 15, 20 days, if you don't eat well, you will develop anemia. So that is a screening thing. So imaging has got a huge, it can make a huge difference, but provided that you learn from the decades of experience, because it's a gold standard. So it is not a comparison between radiology departments, but like all other departments, they just say, okay, fine, this could be. Every report you say, the first year of your blood chemistry or your radiology department or from any other department will say, it's a screening tool. They are going to screen you and say, yes, it could be cancerous. So next, what to do? Go for biopsy. So screening tools are different. Screening tools definitely have a value because pathology, we are, it's a different department, it's a diagnostic department. So screening, you cannot start off a treatment with a screening, you know, diagnosis. Orthopedics is a different exception. So do we have the necessity in pathology? Do we need artificial intelligence? See, if you all have to work with a collaboration with us, we also should be, should also think, yes, we need artificial intelligence, right? We should also feel that it is necessity. So what is the necessity? Is it the presence of images? So, okay, fine, today we have a lot of images coming from histopathology, images coming from urban aspiration biopsy. So wherever the images are there, we'll set up artificial intelligence. So is that the criteria, or your AI is going to make a difference in that patient? That is exactly it. Definitely it does. So shortening, the time shortening from the image analysis, that is what we are expecting from the Department of Pathology. The time and the huge data what we get, the clinical data, the summarizing the clinical data. And so many times when the patient comes to us, especially literate patients, they have huge load of bags of so many CT scans with them. And they don't have the reports nowadays. It's from really the CD level. So where do we have that? Do we have so much enough time to sit and see each report along with your CD? They say, where is my computer? Okay, let's see the photo. So we prefer, even today in feedback, we prefer hard copies. So I said, show me, you want me to see, just get the hard copies, because there are some hundreds of patients queued up. So I cannot be saying that, okay, fine, you put a CD, I can see it will take half an hour. No. So AI can make a huge difference in the data summary of any of the hospitals. So basically, my medical record sections department, that's been where it's happening throughout the world. And so, coming back to the images, so presence of images is one of the indications where AI can have a role. What if no images are there? So, are all my tests depending on the images? No. Few of my tests, I am going to say, your sugar level, does it have an image? No. Can AI play a role in can my transfusion reactions, when I do, does it have an image? So what if there are no images? That is a question where I put. So what if the images are there, I cannot store them? So coming to the Department of Hydrology, why, if you Google and see in AI, mainly diagnostic, you see lot of histopathology. Histopathology in the sense system-wise. AI, artificial intelligence, prostatic carcinoma, artificial intelligence in uterine carcinoma, all organ systems, AI is there. But coming up to your blood cancers, there are very few studies in AI. Actually, that is exactly the unit where actually makes the fastest result. So, where AI can make a difference, why the images cannot be stored in the Department of Hematology is the staining fades away. A span of 15-20 days, the patient comes back. When I go get test ಮಾಡಿಟ್ಕೊಂಡಿರಿ ಡಾಕ್ಟರ್ ನಾನು ವಾಪಸ್ ಬರ್ತೀನಿ ಅಂತ ಬಂದ್ರೆ we can't leave the images because the slide is understained because the type of staining. So can AI make a better stain? So I am going to discuss about the drawbacks what we are facing, problems where we are facing. So can you all have an answer for that in future? So less studies in Department of Blood Cancers in AI, and AI, if you Google and see, in the leukemias, I think the highest data is somewhere around, you have 70 samples, 60 samples, 80 samples. Is it that leukemia load is less? No. We see hundreds of patients. So why there are no images is that we have never stored any of the digital images till today. So coming up. Why? Because it's not a practice in pathology at all. So histopathology, yes. Histopathology slides can be stored for 10 years, 20 years. Whereas your hematology slides, blood, that's not stored. So that's exactly when you don't have storage, when you don't have data, no image studies are there. So no literature, no studies are happening in AI. So this is one exactly one test where I spoke. Imaging is not always, mandatory. You have lot other methodology where we use in the Department of Pathology, like myeloma cases we use electrophoresis, and most of our biochemical, it is interpreted as chromatography, chemical method, radioanalysis, and ELISA is there. So few of the tests are targetometric assays are there. Can all these tests be, linked to an image process? That someone has to look into. Today we see pregnancy test as simple as a pregnancy test, one line with a pregnancy positive negative, right? That see automation is completely different from AI. All of us are aware of that. So there is automation in the Department of Ecology, but AI still has to play a big role. So, so people dealing with AI should always consider the limitation of that particular test. So this is an era of digital pathology. What you should keep in mind when you are looking at the images, you should ask that pathologist, is it a gold standard? Is it a definitive diagnosis or a screening method? Like your pap smears are screening, therefore is cervical carcinomas. So confirmatory, yes, we can give, it can be confirmatory sometimes, but it's generally used as a screening method because just a smear. So confirmation, how do you confirm cervical carcinomas is through a biopsy. Biopsy goes to the histopathology department. So that is your confirmatory diagnosis. So is it screening? Is it diagnostic? Is the test prognostic? I mean, I know the diagnosis of a patient now. He's suffering from cancer. He's suffering from leukemias. So what is the prognosis? So does leukemia patient do better or not? So that kind of tests also we have. They are called prognostic markers. So can AI predict prognosis of the patient the moment I diagnose? So you people with the data, you can say, okay, this is the data of patient A, this is the data of patient B. Whether the patient A makes, he lives long with the current treatment, or patient B needs a different kind of treatment. So that is the role of A which we expect. So do we need any additional ancillary tests for this specific test? So this is from hemato-oncopathology. So I shall take you around the Department of Pathology, taking one unit as an example, because all units I cannot cover, because Department of Pathology is huge. So as I introduce the subspecialties, I think I will take you through hematology department. Hematology department even covers the histopathology because bone marrow biopsies in the same way how your other biopsies are reported. So hematology, you can see, hematology is like, clubbing your cytology also on histopathology. So you know what kind of samples, how we go through. So the entire department of pathology, how it works in a brief I get it. So the moment the patient comes into the hospitals, we receive complete blood counts. So how we draw the moment you see, I go to the next slide. So that's a vena function. So blood is connected. Most of us, I think, at least once in our lifetime, we have got the blood drawn. So what happens to that blood? So we use anticoagulant for the blood. Because the moment you draw the blood, it gets clotted. All of us know that. So it should not clot. So we use an anticoagulant. Anticoagulant of any choice. But generally, there are various kinds of anticoagulants. Why is it important for imaging people? Because different kinds of artifacts and you get different kinds of images. Sometimes your artifacts might look like something else in imaging. So, the common CBC what we use globally is your EDTA. The trisodium citrate is used for your platelet and coagulation studies, and heparin. And then, when do I have to do the test? Can I draw the sample and go back to my house and then come back and do the test tomorrow? Can I do that? And if I do that, what will be the kind of imaging you get? So whatever I'm talking is related to your imaging. So ideally you prefer to do the blood testing as early as possible because there should not be any artifactual changes due to blood itself or due to your EDTA, due to your anticoagulant. So if in case there's some emergencies which you cannot process sample at the earliest, you can store the blood at 4 degrees Celsius, even 24 hours. So these are the different kinds of anticoagulants which we use. Vacutainus with a red cap. Then there is a yellow cap, gray, black, that is the EDTA. And how you can see is, your EDTA, K2 is the EDTA, that's the lavender color. That comes to the Department of Clinical Hematology. The green, we hardly use it, it's in the heparin. So blue color, it is for your coagulation studies, sodium citrate. So what happens next after we draw the sample is, it goes to the hemocytometers. Earlier, we used to do manual counting, so which actually is not advisable. Nowadays, we don't do manual counting at all. So, earlier manual counting was done in yoga counting. Even to make the medical schools, we are taught with yoga famous. Lot of drawbacks are there. So each one of us, even during studentship, we used to get each different values for the same sample. That's all is a manual count. So nowadays, thanks to the automation, so we have hemocytometers. So hemocytometers I will cover up after some few slides. So with the sample, we prepare blood smears. So what are these blood smears? They are peripheral smears. So how is it formed? I will consider the PS on that.
Video.
Video right there.
No.
So this is the peripheral smear. This is taken from kidney. So that's exactly the ideal peripheral smear. What we have in the right side. So this is how we get the town-shaped peripheral smears. We have. Oh yeah. So a drop of blood is taken and the smear is made. So an ideal peripheral smear. So an ideal peripheral smear should be a tongue-shaped or a weight smear. Why is it important is that we have different portions of the smear. There is thick smear, thin smear, and ideally we study in the this is the ideal thickness. If you look at in the microscope, when you look at very thick section, very thick smears, right, you will not see anything. Morphology will not be visible. And your imaging, when you get in case you are imaging, you get maybe in the further future slides I'll show you. The imaging always should be focused in that in between area where I've written ideal thickness. So that is where, and it should be taken there only. So this is smear preparation. All of you saw. So this is very badly made smears here. In the imaging, if you take the imaging from these slides, there are a lot of holes in this peripheral smear. So your imaging also will be bad. So after the smear is done, we stain the slide. We stain the slide with Romanowski stains. Romanowski stains, there's a huge number of stains involved. So methylene blue and eosin. This is the commonest stain which we use. These are group of dyes in the Romanowski group. Visual stain, Gimsa, light, field, tennis, and JSP stain. Why is this important for A? You can find different colors. You can find different staining. Tomorrow you can say, no, that hospital does this color staining. This hospital is giving some purple stain. This is given. It could be the error of the technique, or it could be due to the different stain what you are seeing. If you are aware that different kinds of stains exist, then you understand. So, properly stained slides. We have different kinds of cells in the blood. Red blood cells, your white blood cells, and the platelets. So blood cells are evenly distributed. So erythrocytes should be orange red, and neutrophils should be, purplish, and eosinophils. I'll show you the images here in the further slides. So eosinophils should be brick red or your red orange color. Your basophilic granules should be purplish black. So depending on which kind of WBC it is. So So these are few only to be aware of. So you can get, other than your cells, you can get some of the inclusions. So we would have given you a peripherals here screen for your AI, and your AI is picking up something else. It might be saying not RBC, not WBC, not platelet, something else. So it might be flagging something else. That could be your inclusions, like it could be an R body, it could be an or it could be a caboting, it could be any other inclusions which you find in some other conditions. So this is hemocytometer. This is a five-part differential what we have. So initially what we start with the manual count and then three-part differential and the five-part differential. What do you mean by five-part differential is, as I said, WBC has got five different kinds of cells. Neutrophils, eosinophils, basophils, monocytes and lymphocytes. They initially, when the automation started, we had only three-part differentials. It could only say few of the cells. It could say granular cells, non-granular cells, and then your so now the five-part differential has come. So five-part differential. So here, what is the advantage of automation is here. So we had all manual methods like to see to check for hemoglobin, your platelet, everything. Even that can be checked in your peripheral smear, roughly whether it correlates. Now with the advent of your hemocytometer, you have your correct values. Like the first one, whether you can see that first letter is written your WBC here. Is WBC. The next one is your RBC. The next column is showing hemoglobin, hematocrit. It's giving the value of MCV, mean corpuscular value. Then FCH, NCHC, red cell distribution with RDW, platelet. So it goes on. So many other values are added up with your automation. So your AI, in case any of you are interested in studying AI in peripheral spheres, so that in your peripheral blood, all the sicknesses you will have to know. So with you will get this automated values what so this is the five-part differential what I was talking about. Why five-part differential counting is important is we get your RBC indices. So all your RBC indices like how I said MCV, MCH, MCHC, all that values are called RBC indices. And depending on these RBC indices, we are going to say which type of anemia you have, whether you have iron deficiency anemia, whether you have vitamin B12 deficiency is there, folic acid deficiency is there. So all that can be derived from the erythrocytic indices. So here your AI with your peripherals here, actually when I looked into the literature, AI, there are occasional studies, they are done for normal peripherals here. That too in few hundreds. Whereas your kit-wise statistics, what we have is it runs in lakhs. So one small study, with, one single study can make a difference in the AI in the peripheral spheres actually. So we have data kept because automated hemocytometer five-part differentials are there. We have here huge data. So why do we, coming back to the slide which we stayed, which is called peripheral smear. So we have RBCs, we have WBCs. We have different, resolutions when you look into the smears with the microscope. The one is 10x, 20x, 40x, and the last one down is the 100x oil immersion. So your images also will depend on which power I have given. Whether it's I have given a slide for you 10x, 20x, or whether I have given you 100x. So, as I said in the previous slide, you can make out different. The first line is RBCs, WBCs, and platelets. So, I'm going to cover about the RBCs in detail first. Any questions till now? Did you understand anything? How is it linked to your imaging? Was it useful what I'm talking? You are understanding how a department runs. So there are different kinds of images when you are getting. So what in case the image is slightly different, so you understand that it could be a technical error or it could be a some mix up or it could be that sometimes somebody instead of peripheral blood doesn't BMA, it happens. So you can always evaluate and say, no, this image is not matching, it might be different, just check on this. Human errors are bound to happen that too when the huge data is received. So if there is a check, with the people body with the AI, that's so okay. Coming up to the first cell RBC in our body, what is the number of RBCs? What we can expect? 1, 2, 3, 4. So they are in millions. So you can't expect me to screen all your millions of RBCs and say, Dr. Namrata, please tell me how does it look? No, that's not possible. AI can do. AI can definitely do. So this is one way AI can make a huge difference. AI can pick up in the millions of cells, one cell which is going towards anemia. No, yeah, iron deficiency anemia started, it doesn't affect all the cells at a time, right? So it starts somewhere, it has to start somewhere. So if AI can pick up that cell particularly initially, then that's job is done, my job is done. That's exactly what I'm trying to say. So my talk is based on, instead of saying that, how can I use AI with cancer? I would like the younger generation to say, how can I prevent cancer with AI? Is there a way? Is there a way I can catch that anemia patient before he becomes anemia? That's exactly where AI should play the role. Okay, coming up to RBCs. RBC size is around 7.2 microns, so it's biconcave shaped. The main function of RBC is to carry oxygen to different parts of the body. So it is, as you see on the right hand side, that is how the normal RBC look. It's a biconcave, and central we have around 1/3 para. So that is the normal, any RBC, it's mine or yours, that's how it's supposed to look. So we all are saying, so you have 1/3 pallor in your red blood cells. What happens if the pallor increases? So how do I study this cell? It's a biconcave shaped cell. Its function is it's supposed to carry oxygen. So how do I study this cell? Is it very important or not? So I can study that particular cell based on the size. When the size is decreased, increased, and we on the microscope, when there is anisocytosis is, different kinds size of RBCs are there. I show you the picture. So that generally we grade from grade 1 to 4 depending on the number of your abnormal cells on the peripheral smear. On the slide what we prepare in the 1 drop of blood. In the millions of RBCs I am going to see 1 drop of blood. And in 1 drop of blood on the slide I am going to say less than 10 cells are anisocytosis, more than 10, more than 20, and I am going to grade them. So this is all what a gross eye can do. So what if the AI can pick it up? So AI can easily pick up the size. Okay. So then there is shape, variation in shape. So that is shape. The size and shape thing, no. So poikilocytosis, even that can be graded from 1 to 4. So hemoglobin content can be varied. So with AI we can be able to estimate hemoglobin directly. And if there are any inclusions when I am talking, I am covering up your parasites. Your malarial parasites can come as an inclusions in your red blood cells. So if something in the AI is picking up saying that no, this is not normal RBC, there is something else. You know? So does the automated instruments flag it? No. So our 5-part differentials only says this is this cell. And this kind of cell is increased, decreased. There are some cells which we cannot recognize. It just wax. So can we pick up a parasite in your further care? That is a wonderful thing. So this is your Excel morphology. So normal, this is normal. This is how a normal RBC should look. And there is microsites. See, this cell is definitely a smaller cell than the normal cell. All of you can appreciate. So that is a microsite. So that the next one is a macrosite. When you compare with a normal, when you compare with your normal, definitely this is bigger. This is a microsite. So there it is the shape. Look at the shape. It's become oval. That's an oval microsite. So next, the second column is your hypochromia. So the first one has got only 1/3 pallor here. There is only 1/3 pallor. But here all of you can appreciate the pallor is marked. It's very big. So it goes on, 1 plus to 4 plus it can be graded. This is for the human I am talking about. So you can have a lot of gradings with your AI. AI can make properly from 1 plus to 2 plus a lot of things. Then there is shape variation, there is target cell, there is spirocytes, there are ovulocytes, stomatocytes, there are sickle cells. There are a lot of other inclusions also, including what I said, parasites. There are other inclusions where you can find in different kinds of anemias. You can be familiar with them, saying that papilloma bodies, Cabot string, basically stippling, Havel bodies. And I said AI in blood transfusion department, transfusion department. How you can use AI in the transfusion department? So that to the rightmost corner where I have written agglutination, that is all actually we see in a blood bank. Okay, when before we transfuse the blood, even transfusion department comes under Department of Pathology. Now it is like your hobby or computational pathology is coming up. The transfusion medicine now is a separate entity. So transfusion medicine, there are lot AI and actually it makes a lot of difference for the patient also. So agglutination can be picked up very early in the case of transfusion reactions. And it's the same mechanism which we use actually in the autoimmune hemolytic anemias, where your own body will start reacting against your own body cells. That is called your autoimmune. See, in the blood transfusion, what happens? Some cause some accident or some anemia where you need transfusion, some blood, some blood donor may find they transfuse it to me. So there is a reaction happening. But there will be a condition where your body will start not apart from your hemolytic transfusion reactions, I'm saying, your body at certain stages sometimes, some people will start developing antibodies to its own cells. That is your autoimmune hemolytic anemias. So autoimmune hemolytic anemias, there are disasters because diagnosis depends on a complicated test, which actually not available in most of the things. AI definitely can make major differences in this, where your tests are not available. Where most of the tests we are sending that in the rural areas or in the district hospitals, coming up the medical colleges. See, I found the myself today. So today, if I say the second part where I'm going to talk about leukemias, many of the test names which I say is done only in state cancer institutes. They are not available even in your biggest hospitals like JS, SMC, because the KIPA is a specialty hospital for cancer. So what I'm trying to say is that even the tests which are rarely available with the AI, it can be made available even to the regular. Accessibility can be more. So this is microcytosis, and this is dimorphic anemia. So I don't think we should go through the statistics and numbers and all that because that is not necessary. So this is hyperchromasia. Hemoglobin ಜಾಸ್ತಿ ಇರೋ ಸಾಧ್ಯನಾ? ಹಿಮೋಗ್ಲೋಬಿನ್ ಜಾಸ್ತಿ ಇರೋ ಸಾಧ್ಯನಾ, ಜಾಸ್ತಿ ಇದ್ರೆ ಏನಾದ್ರು ಪ್ರಾಬ್ಲಮ್, ಕಮ್ಮಿ ಇರೋದು ಜಾಸ್ತಿನಾ? So that I think we have to read and tell me. Okay. Next, there are different kinds of cells. Okay, there are white cells, acanthocytes, no, Burst cells. On the right hand corner, on the left hand corner, I have written the diseases where you can find this. So your simple AI picking up different kinds of cell, a different kind of shape can lead to a diagnosis. So that is what is my talk about. My talk about, but it's not about peripheral sphere. It's about AI application in your peripheral sphere. So if you apply, if you say, see the right hand, you feel happy, the right hand, all the diagnosis which is very difficult to make diagnosis from my side, you will be able to guide me and say, no, Dr. Namrata, this is G6PD deficiency. That is where AI can play a major role. Okay, then different kinds again. Sickle cell anemia, cystocytes, spirocytes, target cells. So these are different. They are terminologies where you find different kinds of abnormalities in the red cell. So so coming back to, I have started with red blood cells. So with the red blood cells, you can help me classifying the anemia, and you can also help me by patient not coming to me saying that yes, I'm healthy because AA has picked up at the initial phases, so I have not developed any anemia. So as I said, Kidwai runs a huge workload. So anyone interested in the red blood cell morphology, because if you screen a normal population and properly through entire static reports, properly it's very difficult to get 1 lakh sample for you all. And even in that 1 lakh sample, you might be getting majority normal samples. Whereas in Kidwai, your AI, the major thing what you have to concentrate is where you get abnormal samples. Because normal samples, yes, definitely you can get from any of your hospitals. But abnormal. So, this 1 lakh samples I actually will give all of them abnormal. All of my patients with the chemotherapy or see, what I will be very happy if you can screen them and tell them, whether it's radiation therapy or chemotherapy, anyone developing anything, and yes, this can be changed. Many of the changes what is happening in the RBCs might be due to the toxicity which they develop due to many of the drugs. So if you can tell me, okay, this drug is there and this RBC change is happening, this particular change imaging is following this particular batch of patients, what are receiving treatment. So that can be one of the things. So coming up to my second WBCs. What is the function of WBCs? They have a strong role in the immunity. So battling for your infections. They protect you from your infections. So this again depends on the number of count, shape, everything as the main gist of my talk remains the same. Shape, size, everything else. The texture analysis also can be done by AI, whereas my eye cannot say about texture. Right? Mine is only 3D. So next, these are the different kinds of cells: neutrophils, lymphocytes, monocytes, and eosinophils and basophils. And as I said about the RBCs, in the WBCs, each cell can be taken into a neutrophilic changes. That can be studied. Lymphocytic changes can be studied. So each one. So it's never ending. As I said, that is the normal range in an adult population. So this is the imaging, okay? After a long time, I think you must be happy looking at an image here. So this is a neutrophil. And this has got many lobes. If you can appreciate, this has got many lobes. No? 1, 2, 3, 4, 5. So that is the nucleus divided into 5 lobes and surrounded by the cytoplasm. The cytoplasm has got cytoplasmic granules. We have to literally keenly look into it. So, cytoplasmic granular abnormality is also a disease. So even that AI can do. So your neutrophilic lobes, very easy to make out by gross eye. So what I say in the neutrophilic disease is just hypersegmented neutrophils are seen in vitamin B12 deficiency. So this is vitamin B deficiency most likely, clubbed with probably some other deficiencies. So can you help me with your artificial intelligence who's got more eyes are much better in AI than yes, it can be done. So this is also a WBC, this is a lymphocyte. Then this is a monocyte. It's a large cell, nuclear indentation cell, and it's got 5 granules in it. So anyone try to look the RBCs at the background? Please look into the RBCs in the background. I shall go back. See, none of my slides are only about WBCs. See, they are always accompanied, right? We have all of the sets in us. So can you see the parlor at the back? Can you see the RBCs what I just spoke? So what I showed you in the diagrams, almost all cells are there in the background there. So that itself can be a study, millions of cells. Can we, okay, monocyte. So the left hand, the right hand side is the eosinophil with the brick red granules in them. It's got very coarse granules, very easy cell to identify. The lobes are like spectacle shaped, you see. The left side has the basophil, which your nuclear lobes are not clear because the coarse granules are covering them. I showed you the initial 2 slides earlier saying that this is the percentage of WBCs which you can find in the normal population, adult population. But can they vary? Yes, they can vary. The huge biology is a complex mechanism. With the imaging, what you have to understand is biology is not static. So morning, what I do, your WBC count might be 4,000, but by afternoon evening, when I look into it, it might be around 5,500. I see most of my patients again discussing themselves, saying that when I get more into fire, I'm very happy. So we don't stop them because let them be happy, they are chemotherapy patients. But is it just the storage pool what we are talking about? It's a normal variation of your cells into the peripheral blood. So what is the RBC lifespan? RBC lifespan is around 120 days. So what is the WBC lifespan? So I want you to look into it and say what are the WBC lifespan. So there are few days to few weeks. So what WBC, what you look in the morning, what you capture them tomorrow might be a different. So that's exactly the reason. So coming back to my slide. So you can have lot of variation. See in the birth you can see neutrophils, the second column, neutrophils are the majority of them. They are around 61. Okay, coming back to your around 6 months of age, you can look into it will become 32. Okay, so what I need to say is with the age they vary, with the duration in the same day they vary. So variation is a phenomenon in biology. So this is again hemocytometer what I showed you. 3.5 part, yeah, 5 part. We do get scatterograms. See, I have put this for imaging. People will get more interested in the peripheral blood analysis. There is an image here. This is automated. 5 part differential. Why I said 5 part is, see this is, you can see 5 colors here, yellow, pink, blue, and there is white, and there is green here. There is a histogram also here. So there are 5 part differential is each cell falling on to the different colors. With the whole term we have 5. But does that say it's cancer? No, it doesn't say. So, but yes, definitely it gives the pathologist an idea when they're screening. Yes, And I look at Instagram, I put the slide faster. I can give more time to a very bad slide. So this is normal. Neutrophils are dominant. Where you're, the green one is the eosinophil. Whereas the blue thing is your lymphocyte with CD45 less screening. The granular cells, see how we differentiate is depending on the size on the X and Y axis, we have one year complexity. The complexity is your granules. So the more I showed you few sets of your WBC center, neutrophils, monocytes, eosinophils, all of them are granules. So you have granules, they fall farther. Cells with no granules, they fall towards. So depending on the complexity, they fall. So as you see here, neutrophils, color coding is there, you can see. Neutrophils are fallen here. So your monocytes are lying here. Your eosinophils come up here because they've got strong granules in them. And this is blue. That those are agranular, what we call. So lymphocyte. So depending on your size and granularity, your scattergram also can differentiate. That also can be studied actually. We have around, again I do the same thing, around 1 lakh histograms. People can analyze with the imaging. So as I repeat the same thing again, the count we can do shape, size, volume, texture, distribution, location. Coming back to the third type of cell, platelet. Platelet, they are they don't have nucleus. When I speak about the bone marrow, then the second half I tell you where they take the origin from. So this is like, initially when we started 20 years back, we did not have your hemocytometer. We used to keep the total count of the newborn counting chamber. And then when each of us used to get each different values, then the madam used to come and say, give me the smear. In the peripheral smear, she would accurately say, this is the count, please go back, you can start your chemotherapy. So we were wondering how this lady with the experience, like how is she saying the count accurately. So now, that's exactly, so that's the direct. So if you see per slide, the per oil emulsion around 5 to 15, that's an adequate. So there's something called platelets in there. What you can see once you draw CBC, your blood test, let's say, platelet, I think most of you are interested. Platelet karna protein and dengue protein. So is that true? Is that true? Yeah. It could be true. If you have fever or you have symptoms, that's exactly why when the platelet low is there, the hematology person from the lab, you will then see them with the white coat saying that from here you have fever. Instead of running the second sample will cost me again. It will go to the patient again, he has to pay again. So instead that we will call whether do you have any symptoms, why are you here? So is it like I showed you in the anticoagulants, initial sites, blood, the moment you draw, they get clotted, it gets clotted. So to prevent the clotting, we put anticoagulants. Is it due to anticoagulant? We are having platelets now. The one chemical which is supposed to prevent clotting is causing platelet loss. So should I use that anticoagulant or not? So this doesn't happen with all the patients. And sometimes once in a while we get samples saying that platelet is low, but the patient doesn't have any symptoms. So we go back, we make the smear and see, as I showed you, 10 to 15 per oil emulsions, right? We look at it and say, no, the platelet is normal, it's not looking low. So what do we do now? So we can go back and ask for a different anticoagulant. We ask an heparin sabarkasuri. So that is where your different anticoagulants also help. So this is called, especially it happens in the ETA sample saying that platelet samples. Platelets being small, nasal blood, they get adhered to the RBCs and WBCs what you saw. At the control blood. So unconventional platelet individual counting comes down. Okay, these are platelets. So these are the platelets. The small purple dots, this. So they are the platelets. This I should say in the bone marrow. So there are studies in the AI. If you Google, you get a lot of literature. I didn't concentrate about the articles because just putting the articles is not my purpose of coming here. You Google, you get many articles. So there is one such article where your image-based analysis of peripheral blood on a normal sample is done. So this is one thing again which aids us in cell identification. And this is how we report saying that your RBCs are not authentic normochromic. Chromic I showed you the color. Size I showed you. Cytic means size. So it means the normal size and the normal hemoglobin. So WBC is again the same thing. Platelets are adequate. There are no hemophagocytes what I am seeing. And in case I am suspecting any leukemias or any platelet cytolytism, I will ask for a fingerprint study. So now, okay. So let's stop at just saying that okay, one simple slide. We went through I think 1.5 hours. Now again we start getting calls and actually saying that we are peripheral smear is done in half an hour to 1 hour. This happens within 1 hour. The patient is walked in and I have a report, immediate automated report in my hand. That takes only 3 minutes. That is the positive about the automation. So but my slide gets ready in half an hour, 1 hour. The slide is not even right. The technician comes, madam, emergency, they tagodi. They just keep on the slide and they vanish. So what do I do next? So this is what is going in my head. So let's have a coffee after this.
So you are requested to have a tea break just outside this hall. Please join us for a tea. No, just really.
ನೋಡಿ ಬ್ರೋ, ಇದೇನಾ
ಇವೆರಡು ವಿಡಿಯೋ ವಾಟ್ಸಪ್
ಸರಿ ವಾಟ್ಸಪ್ ನಂಬರಿಗೆ ಕಳಿಸ್ಬಿಡ್ತೀರಾ ಅಥವಾ
ನಿಮ್ಮ ನಂಬರಿಗೆ ಹೇಳಿ.
ಸರಿ 63 66 00 103 ಅಲ್ತಮಶ್. ನಿಮ್ಮ ಹೆಸರು? ALTAMASH. ನಿಮ್ಮ ಹೆಸರು?
ಸಹರ್ಷ್.
ನನ್ನ ವೆಬ್ ಆಲ್ರೆಡಿ ಕನೆಕ್ಟ್ ಆಗೈತೆ ಅದಕ್ಕೆ.
ಹಲೋ, ಎಲ್ಲಿದ್ರಿ ಎಲ್ಲರೂ? ಅದೇನದು ಟಾಪು? ಯಾರು? ನಿಮ್ಮೆಲ್ಲ ಯಾರು ಕರ್ಕೊಂಡು ಬಂದಿದ್ದು? ಹಳೆ
ನೀವು ಇಲ್ಲೇ ಇರಿ.
ಸ್ಟೂಡೆಂಟ್ ಫೈನಲ್ ಇಯರ್ ಸ್ಟೂಡೆಂಟ್ MITM ಫೈನಲ್ ಇಯರ್ ಸ್ಟೂಡೆಂಟ್.
ನಿಮ್ಗೆ ಏನೇನು ಸಬ್ಜೆಕ್ಟ್ ಇದೆ?
ನಮ್ದಾ ಈ ಸೆಮಿಸ್ಟರ್ ಎ ಐತೆ, ಮೆಷಿನ್ ಲರ್ನಿಂಗ್ ಐತೆ,
ಅವಳು ಅನನ್ಯ
ಡಿಪ್ ಐತೆ.
ಅದರ ನೋಟ್ಸ್ ಏನಾದ್ರು ಸರಿ ಶೇರ್ ಮಾಡಿ.
ಶೇರ್ ಮಾಡ್ತೀನಿ.
ನನಗೆ ಅದೇ ರೆಕಾರ್ಡ್
ಕಳಿಸ್ತೀರಲ್ವಾ ನೀವು? ಕಳಿಸಿದ್ರಲ್ವಾ?
ಒಂದ್ಸಲಿ ಪ್ಲೇ ಮಾಡಿ.
ಹಾಂ ಸರಿ.
AI ಬಿಟ್ಟರೆ ಇನ್ಯಾವುದಾದ್ರು
AI ಆಮೇಲೆ
ಮಷಿನ್ ಲರ್ನಿಂಗ್,
ಮಿಷಿನ್ ಲರ್ನಿಂಗು, ಡಿಪ್ಪು ಹಾಂ, ಅದು ಬಿಟ್ಟರೆ ಓಪನ್ ರಿಲೇಟಿವ್ ಇತ್ತು ಅಷ್ಟೇ. ಓಪನ್ ರಿಲೇಟಿವ್ ಮೆಕ್ಯಾನಿಕಲ್ ಅಷ್ಟೇ, 4 ಸಬ್ಜೆಕ್ಟ್ ಇರೋದು ಸದ್ಯ. ಇನ್ನೊಂದು ಯಾವುದು ಐತಲ್ವ ಥಿಯರಿ? ಅಷ್ಟೇ. ಹಾಂ IoT. ಹಾಂ IoT ಮೇನ್ ಸಬ್ಜೆಕ್ಟ್. ಇದು ನೋಡು ಬ್ಯಾಗ್ ಪ್ರೆಸೆಂಟೇಷನ್ ಎಲ್ಲಿಗಡೆ ಆಗ್ತದೆ
ನೀನು ಹೇಳ್ತಿರೋದು ಅರ್ಥ ಆಗ್ತಿಲ್ಲ.
ಇದು ನೋಡು, ಕೆಳಗಡೆ ಮಾಡೋದು ಕ್ಲೋಸ್ ಮಾಡಿಬಿಡ್ತೀಯಾ? ಹಾಂ ಬಂತು ಬಿಡು ಸದ್ಯ.
ಏನು ಮಾಡಲಿಲ್ಲ.
ಏನು ಯಾಕೆ ಎರಡೇ ಸಹರ್ಷ್ ಎರಡೇನಾ ವಿಡಿಯೋಸು? ಹಾಂ ಸರಿ. ಇಲ್ಲ ಅವ್ರ ಜೊತೆ ನೀವು ಹೋಗ್ತಿದ್ದ ಏನು ಮಾಡಿದೆ? ಈಗ ನೋಡು ನಿಮ್ಮ ಫೋನಲ್ಲಿ ಬರ್ತೈತೆ ಎಷ್ಟು ಇವ್ರು ಬರ್ತಾವ ನೋಡು ಲೈವಲ್ಲಿ ಹೆಂಗೆ ಮಾಡ್ತೈತೆ ನೋಡು ಒಂದ್ಸತಿ. ಬಾಜು ಮಾಡೋಕ್ಕಾಗಲ್ಲ. ನೀನು ವೇತನ ಬೇಡ ಕಣೆ, ಬೇಡ ಕಣೆ.
ಟಿಶ್ಯೂ ಪೇಪರ್ ಹಾಕ್ತಾರೆ
ಟಿಶ್ಯೂ ಪೇಪರ್
ಟ್ರೇ ಮತ್ತು ಮೊಮೆಂಟ್ ಬಾಲಕೃಷ್ಣ ಸರ್ ಕ್ಲಾಸಿಕ್